Yeah, I mean, again, good for you. If you have a great freezer and a good way to keep those good, but I just, for me, it's like I don't charge that much because I have a, decent margin. So I instead of taking these other manufacturers up, I have the luxury of being low price and the same product. So for me, it's not
So
worth
it,
it.
Hey there, welcome to the Recharge Biomedical Podcast. I'm Dr. Edward Park, and if you're curious about regenerative medicine, you've come to the right place. We're diving into the latest breakthroughs in telomerase activation, stem cell exosomes, and all the cutting edge science that's shaping the future of healing and longevity. Let's get started. Hi, everybody. This is Dr. Ed Park. We're doing another monthly Ask Me Anything webinar, and today we're going to talk about back pain. First of all, the back is very complex, and so we really need to dumb it down to the basic principles. Jason is calling, I think, from Puerto Vallarta, and he had some questions, which were great questions. And so he asked, and you can submit your questions even if you're not attending live through the website, and that's in the email that we send every week. So he asks, in a case where a patient presents with bilateral L5S1 radiculopathy with denervation, minimal reinnervation on one side, and a significant disc desiccation at L5S1, along with multi-level disc bulging and spinal cord compression in the cervical spine at C5-6, what regenerative approaches would you typically recommend? Would you consider targeted stem cells or exosome injections, nerve hydrodissection, or perhaps a combination of these therapies with advanced physical rehab, given the chronic nature of the nerve damage and disc degeneration? And that was Jason's question submitted through the website. Well, aside from the very run-on sentence, there's a lot in there to unpack it. So why don't we just take it slowly and simply? We'll have a couple of patient testimonials that will give you an idea, but let's talk so we are all on the same page, shall we? Okay, so 80% of people experience back pain sometimes in their lives. It's a leading cause of disability. The back pain increases, of course, with aging. And think of it as like your transmission. I mean, it's got your electrical in there. It's got your powertrain. It takes a lot of mileage, and so everyone is heading towards back problems, the bottom line. So what is the normal anatomy? Well, we can see here that there are three curves in the spine. In the neck, it curves forward, called lordosis. In the thoracic spine, it curves back, called kyphosis. Then in the lumbar, it's forward again. And then in the sacrum, which are five fused vertebrae, it's again kyphosis. And that's what actually defines those segments. So it's made up of backbones, these vertebrae. And so let's talk about what's between the vertebrae. Between the vertebrae are the discs, which are these amazing annular collagenous structures that are firm and yet jelly, like sneaker jelly in the middle. And of course, that's shown at the top right of the slide. So this jelly can protrude when the circular tough fibers get weak for whatever reason. And we'll talk about that. But also the vertebrae are joined by these facet joints. So the reason you can twist and bend and flex is because the vertebrae above interarticulates with the one below and above. So those are the facet joints. Running up and down the spine are ligaments, which are like a Spanx girdle that keeps the disc in place. And those can also get weak or inflamed. Bottom left, you see in red, the anterior longitudinal ligament is one of those Spanx ligaments, like a sausage casing. There's one at the back holding the disc in, and there's one on the other side of the spinal canal as well. So a variety of muscles interact on these vertebral bodies, and then there's cartilage and facet joints in between. Some of these muscles you see are these tiny little multifidus muscles, and that there are very powerful muscles like the psoas, there are hip flexors that are often the cause of lumbar problems. So why does your back hurt? Well, in most cases, it's the lumbar spine. We're bipedal hominids. We walk around, we sit too long. We get weak abs and glutes, so that can show up in poor posture on the top right. You see a sloucher, that's me. A lot of times we're at the desk, we're slouching, and so that can cause cervical spine problems. Yeah. People who walk have strong glutes and strong abs, and that's really good for preventing back pain. I remember one time I had terrible back pain, and it was from having a scooter that I never walked anywhere. I became a total vegetable. And my Rolfer, who was a patient of mine, said, "Oh, this is why." And I learned and I did some walking and it went away. So we have to be cognizant that there are congenital problems like scoliosis, but a lot of it is lifestyle related. If you're walking, then you have a good balance of forces, and hopefully back pain will be slower to come. Once you start getting these problems, everyone has osteoporosis. As we get older, it's a depletion of stem cells. So you have these fractures that come up. And then, you can lose water content and collagen content in the discs. So they can cause, cracking, protrusion. The ligaments can become weak. But mainly, I think the chiros are right. The subluxation, meaning the misalignment of the vertebral bodies, is key. And so even there's forms of nerve compression just from being too strong on one side with your hip flexors. And that's something we talk about in a couple of the back pain webinars that I've done. When it gets to the point of radiculopathy, which was Jason's question, you can see the homunculus or the guy here in the mauve and the blue and the yellow and the green. These correspond to the cervical, thoracic, lumbar, and sacral nerve roots. And so you know exactly, based on where their pain is, which nerve is being compressed. And it's lateralized, right and left. Unusually, people can have bilateral. So we have to figure out what's going on there. If you look at the cartoon there, you can see what that looks like. A disc protruding. You see the light blue squeezing out, and that can knock out the nerve on that side, cause foot drop, cause excruciating pain, as we'll see from Peter in our live interview. Muscles can also cause radiculopathy. The powerful psoas that I talked to you about is the hip flexor. When that's asymmetric, like it's stronger on one side, then it can pull the vertebral bodies and cause squeezing out on the contralateral or the other side, shown there in the middle diagram. And if it is just from a strong psoas, the psoas syndrome, you can actually stretch out the contralateral side and relax it, hopefully. There's also piriformis impingement, which means these tight little hip rotators form a passageway for the sciatic nerve, and if they get in spasm, also causing sciatica. Now, spinal stenosis is kind of a misnomer, so think of it like this stack of tires, yeah? So if you go to Big O tires or whatever, the tires got to be stacked. If they're not stacked perfectly, then what happens? Then the potential space of the canal is no longer maxed volume, and so you get impingement. And spinal stenosis is a very different animal. So you can get this in the neck, but more commonly in the lumbar spine. And it just means that you're subluxed. So oftentimes it's the sacrum, or those five fused vertebrae. But typically the tell is that people feel better when they lean forward, usually. And so it can cause bilateral disease. It can even cause erectile dysfunction, bowel and bladder problems. And it's very, very bad. So how do you fix that? Well, in the top right, you see a terrible subluxation, right? And that is not going to allow for normal nerve function. So every time you slide and the back remains in that slid position, the nerves of the spinal cord could be compressed. And it's typically, even though the spinal cord is not solid like sugar cane, it's loose hairs like a horse's mane or a horse's tail, they call it the cauda equina, it could still cause problems. All right, so what do we do? Prevention is key. Being active, walking, good nutrition, preventing osteoporosis with D and K. When it comes time to protrusion, the docs and the patients like a microdiscectomy. It's a pretty minimal surgery, and they can just cut off the disc. Mind you, you have less disc. It doesn't fix the problem. But I have not heard great things about artificial discs, quite the contrary. And I don't think it's ready for prime time. I think that these fixation rods or Harrington rods are kind of a last-ditch thing. If you need it, you need it. But 99% of doctors asked anonymously at a conference who do this surgery say they wouldn't do it on themselves. So for all intents and purposes, if you can get away with yoga, stretching, light exercise, core and glute walking, strengthening, then that's great. So why do we do exosomes? Well, a lot of people say, is this FDA approved? Most of the people in my referral pattern have gotten multiple steroid shots, which are not FDA approved. The scientific data and the epidemiologic data says it's not helpful, but people want to help and it's paid for by insurance, so they give it a go. But we know that steroids are toxic to stem cells, especially the ones producing the cartilage that make up the discs and make up the ligaments, and even osteoporosis can be caused by steroids. So it is not a logical nor scientifically based or epidemiologically proven thing, but it's paid for, so people do it. Could it be accelerating disease? Yes, quite possibly. So where are the treatment areas? The question Jason asked is kind of illustrated on this left cartoon. You have a needle with a little curvature, it's blunt, and you're trying to get to the epidural space. This is what a woman in labor will get, an epidural. So it's not that difficult, around 4 centimeters. You just keep on finding it. And there's a video on my website and my YouTube channel demonstrating this. You just gently pump the syringe, and when you hit the epidural potential space, you lose resistance, and it's pretty easy. It's not even as dangerous because you're not threading a catheter for continuous analgesia or anesthetic. So you get it in there, and of course, the epidural space is a potential space. This is not usually one that really exists. So you put some volume in there, and it'll dissect around and up, basically to the ligaments, around to the discs, sometimes to the nerve roots. And so this is the basis of why we think it's working. If you want to get to the disc, you see that there's a straight needle going through the epidural needle that's puncturing the spinal canal. So you have to traverse the spinal canal to get to the other side to get to the disc. And that, I think, is very technically difficult without live fluoroscopy. Ultrasound arguably is not good enough to penetrate and guide that. But for usually our purposes, we're doing epidural needle placement. I hope that explains it. I want to share a couple of videos, and I think they'll be illustrative. One I just did 30 minutes ago. So we're with Mike. So about 5 years ago, this month, you had sudden back pain after a 2-day trip. And then what was the diagnosis?
Just a bulging disc. Just my disc has the height, but it's malnourished, so it's black on the MRI instead of white.
Yeah.
And it's slightly bulging posteriorly out the left side, so it's kind of pressing on the nerve.
So you've had sometimes pain shooting down the side of your calf and whatnot, L4, L5?
Yeah, mainly.
So they did the microdiscectomy. Did that help at all?
No, fortunately.
So it's kind of an alignment thing. It's kind of a disc thing. So
Yeah.
have they told you to do surgery? There's no more surgery.
I mean, the surgeon said maybe do a fusion, but
Ew. Yeah.
no.
So you did like 150 hyperbarics. What else did you do? PRP?
Yeah, PRP, some lesser exosomes that didn't do anything.
Where did you put them? IV or in the back?
No, they did them with the ultrasound just down the sides.
Oh, yeah. The muscles. That doesn't help. Yeah.
Yeah, it did.
So then nothing really moved the needle. You just
Yeah.
been in pain like 6 to 8 out of 10 for years now?
Yeah, it's the
Okay.
biggest trial of my life. Yeah.
How did you find...
My daughter's 4, I've never held her. I've never I mean, it's, there's been a couple moments, but
Yeah. No, and you're at the soccer game. You're lying down. The people are noticing you're in pain.
yeah.
So that's ironic. Yeah. So you make a red light device in your company, which Keter Dimiondis uses. That's amazing.
Yeah.
But sometimes you need a little biological help. So in December, how'd you find me?
Dave Asprey.
Oh, yeah.
As a podcast. Yeah.
Yeah. So you got a shot, and for 3 days, it was like nothing, right?
Yeah. It was like it completely changed my perception of my pain because nothing had ever turned it off. I tell people it was like April 2020, somebody flipped a switch and it never got flipped off. So those first few days, the pain was gone, and I was like, this is something.
But then it kind of crept back. It wasn't built in a day.
Yeah.
So you came back last month, and then how long did it help?
Yeah, almost 3 weeks.
Wow.
Which is just like
Zero pain.
zero pain.
Zero radiculopathy.
I mean, it was
Wow.
like nothing. It was crazy. I was I was almost nervous. I was like, what is, this is so foreign,
But eventually,
imposter syndrome.
right. No, but in the last week, something started creeping
Yeah,
back.
it kind of crept back.
Yeah. So, but out of a scale of where you were, 8 out of 10, you're what, 3, 4 out of 10?
Yeah.
Oh, good. So you can see the improvements. So you're not giving up. You're saying,
No, I've finally can see I was an avid golfer. I was trying to be a professional golfer, which I think is called the rotational.
Worst, yeah.
But I haven't been able to do that with my son. And
What did you get to?
I'm
sorry, at his hat?
yeah,
Wow.
yeah, I loved it. I mean, I did it 10 hours a day.
I saw the Masters this year.
Oh, it's so cool. Yeah, I loved it. Yeah, I haven't watched a ton of golf because it honestly kind of gives me PTSD.
Yeah.
So because I can't play, but this is the first time I was like, I got to watch the Masters. But
All right, so we're going to try and do the triple strike. They're going big. I know it's a stretch, but we're going to sell out a red light and get you back going.
Yeah.
Productive. Family man. Young
it's
kids.
been a blessing. Thank you so much. It's changed my perception of what my life can look like. So
Yeah, and we don't even think it's COVID related. It's just that long drive. You never got COVID or vaccinated or anything?
I got COVID. It kicked my butt for a couple weeks,
Yeah.
but I never got vaccinated or anything.
All right, cool. Let's do it.
Okay.
All right. Here's the stuff, and this is the good stuff. I don't even know what brand you used before, but obviously,
It wasn't.
well, even Paraspinal's not gonna help with this. Yeah. Okay. How are you, Peter?
Pretty good, thank you.
Good. What was the problem for you're 79? What was the problem for how many years?
Probably only 2 years.
Yeah.
I've obviously had scoliosis my whole life,
Yeah.
but it never bothered me. And in the last year and a half or 2 years, that's when it really started to bother me. And it wasn't so much in my back; it was really the back causing terrible pain in my right leg.
Right. So you have what we call radiculopathy. So it's like the nerve is getting pinched, right? So
The nerve
what did that feel
pinched.
like? Yeah. What did that feel like in your foot?
It was very painful when I was trying to walk, and I really couldn't walk any distance at all. And it was very demoralizing because even though, I'm 79 years old, I feel, as everybody says, I feel much younger, and my attitude is still of a much younger person. And it started to make me feel more my age, and I didn't like that very much. So
So just this burning pain on the side of your foot and some muscle wasting. Were you able to stand on your toes on that side?
I probably could stand on my toes. Yeah.
All right. Okay. So we did the epidural injection. And so what happened? How was the quality, the amplitude of the pain?
It took a number of weeks for it to start to feel better. And the interesting thing, or the good thing about taking the cruise, was that there is a lot of walking back and forth in terms of going to your room and going to restaurants and going
Really?
entertainment. And I've done this twice before, but I still felt like it was overwhelming. And then it wasn't because I was not experiencing the pain in that foot or in that ankle at all. In all that.
At all. Okay. Fantastic.
Not at all.
All right.
Yeah.
Well, that's good news. All right. So maybe next time we're in Miami, we can get you a little, but how, if you have no pain, how can we get any better than that?
You answer that question because, we discussed this when I saw you, and I don't remember if, oh, this is good. Now this is it for the rest of my life, or, this is going to come back or it's going to come back.
Well, I don't know if it'll come back, but okay. All right. We'll talk about it further, but I thought you'd say, the pain is like 20%, 30%, but if you're walking around the poop deck and you're dancing to the salsa, then it must be pretty good there.
Was surprising that it was pretty good there. Yes.
Okay. Well, that's good. Mazel tov. Happy
you.
anniversary. Happy birthday. And
Thank you.
thanks for chatting with us.
Of course. Thank you.
We age because our telomeres shorten and our stem cells deplete. But what if we could support both? I've been taking TA65 for 17 years. It's the only supplement I trust to support better mood, better sleep, and exercise recovery. And at age 57, I don't have any gray hair and I don't need reading glasses. TA65 is available now. Go to rechargebiomedical.com/TA-65 and enter promo code RECHARGE10 to save 10% off. And so that was a good result. Since then, some of it has come back, and he feels it's because we were one disc level off. Even professional anesthesiologists are off 30 to 50% of the time in their disc level. Are there any questions that people want answered?
Okay, can you hear me, doctor?
Roman Gregory, yes, sir. Go ahead.
Question about dosages, really, and then the frequency of administration.
Yeah, okay, this is a great question. It comes up a lot. The fact is, and if you watch my interview with Duncan Ross, the owner of the exosome company that I use, nobody can really measure quantity. So unfortunately, all these people who are like drug rep detail people, they play fast and loose. You can't really measure exosomes. So what this company I use has been doing is they do probably size exclusion, inclusion, filtration, and then all the safety testing, and then they measure them for RNA content. The thought being that RNA content is how potent the exosomes are.
And if you want to take a deep dive, watch the podcast that was just released yesterday about that. But even you go to these conferences, I just came back from Vienna 2 weeks ago. The scientists, the manufacturers, nobody can measure exosomes. So when your rep comes in and says, I can give you 100 million, which is, 10 times more for half the price, I can guarantee you they don't know what they're talking about. So because I've only used one brand, the dosing in my own thought process has been consistent. I keep records of it, but it's a great question. No one can really answer. But generally, exosomes are denominated in the 10 to the ninth or billion, and stem cells are in the million, right? So that's a little different. It can vary as low as, 1,500 up to even 6,000. Any other questions to be typed or asked? You can raise your hand, or Vicky has a question. Go ahead, Vicky.
Okay, so stem cells, can they be injected directly into the SI joint?
Yes, the short answer is yes. So, stem cells, anecdotally, they probably work pretty well. I am conflicted over it because you're taking someone else's, usually, unless it's autologous genetic material. And Duncan was saying yesterday, like, these cells don't even survive a day, according to science. And then you go to conferences and you go to people who do stem cells, they say, oh, no, they engraft, they live forever. So I don't think the truth is really that close or in between. They don't usually last forever, maybe days. And then your immune system tracks them down in most cases. But the answer, anything that you got results with PRP or stem cells, you can do just the exosomes. Because remember, the PRP works because of inflammation, which brings in stem cells, which secrete exosomes. So now you don't need the stem cells or the PRP or the inflammation. Jason has a question. Here we go.
Hi, Dr. Park. What's your opinion on the Muse stem cells that the multi-lineage Strappern thing?
Great question. Okay, so Muse cells are discovered by Japanese scientists. There's some people doing them. They're very expensive. So the reason they like them, what we deal with usually is adult stem cells, meaning a newborn placenta is an adult. It doesn't have the pluripotency of, let's say, an embryonic cell. But Muse cells appear to have much more pluripotency. So there's promise there. They can switch a little easier. My intuition says that I don't think that that's all they're cracked up to be, because I think the reason we see Muse cells, and maybe all we're really witnessing, is Mother Nature taking an existing stem cell and de-differentiating it just a little bit so it has more potency. But as far as using them, if you're talking about using a stem cell that has more potency, you also take on more risk of teratomas, which are multi-germline tumors. So I don't see the benefit. They're very expensive and for research purposes only. I think it just more elucidates stem cell ecology, which is something that nobody really understands. I'm going to Hong Kong in 3 weeks to try and understand, but I can guarantee you it's definitely a great marketing thing, but I don't think it's for use in humans yet.
Ask another follow-up. For the sake of the argument, I assume all exosomes are created equal. And I recently, kind of biohacked myself with a Trillium Plus. I had fabulous results, but that was just an IV together with the DPC 157, a few other ingredients added. And I understand that, IV is one thing, direct injection is a different one. But again, trillion, 2 trillion, half a trillion, so many mLs, usually, 2 ml. And again, what are the exosomes are dissolved in, I guess? It was supposed to be amniotic fluid.
Yeah, all right.
Can you talk a little bit about that more precisely?
Of course, yeah. So I would encourage you to watch the video I did yesterday with Duncan Ross, and he's kind of talking about that all exosomes, unfortunately, are not created equally. And even within his process, he's learned that different things make them more potent, less potent. He's talking about amniotic fluid, have no mRNA. So that assumption that all exosomes are created equal is quite debatable. In fact, what Chimera 2 years ago went to playing the same particle game. So really, if I brought you distilled water and put it in one of these machines, I could call it a trillion of exosomes, because it's just measuring particles. So the machine can be set to measure and give any result you want, sadly. So
really, some manufacturers have better quality control, some don't even monitor quality control, and every cell makes a wide range of exosomes, and it depends on how they're curated. So it's like comparing apples to aardvarks. I mean, there's some manufacturers have great potency, some have great marketing, but I've never met a rep, someone who's selling it, that really understood what an exosome was and how to measure it. It's just way beyond apparently their interests. So, yeah, you can't really go by particles. Yeah.
Let me rephrase. Basically, yeah, I absolutely agree with you. I was more in terms of like, again, the basic explanation to a patient. But I could say, for instance, okay, if I first do it intravenously and the same night I sleep for 12, 14, 20 hours, that means, yeah, it's working. You know, second night I sleep again. That means this particular batch is definitely compatible with my, body. So,
Are you a doctor, Roman?
MD,
Okay.
PhD.
Yeah. So, I like what you're saying about having a heuristic or an active test. And again, 100% agree. People who get somnolent, it tends to be a good sign. But the problem is there have been, I would say, 13 or 14 manufacturers. Maybe 4 of them have gone out of business. And it's a case of really not knowing what you don't know in terms of manufacturing. And we can all do safety testing, but you alluded to one batch being stronger than the other. In the 6 years that I've used this brand, I felt maybe one batch wasn't as strong, but they do have internal validity testing. So, for example, when you say 1 trillion, now the products are measured in trillions of particles, whereas before they were in billions of exosomes. So everybody's playing the game now, but it's hard to really compare, in my opinion. But yeah, if you have great heuristics like sleep or, obviously the reason we continue to do this after 6 years is because on average, about 70% of people just get better. And so whether that's black magic, placebo, or some kind of biological mechanism, which is rooted in science, who knows? But as long as people are getting better, then it's ethical to keep on treating.
Well, my point is, this is my next step is like, okay, if I respond really well by sleeping immediately after the IV, then I can proceed with knee injection, spine injection from the same batch.
Oh, I see. See, I never had that batch concern or question because everyone I've gotten has been good. I see it's like a heuristic, and then you're kind of saying, okay, the patient's going to react to this batch. I never question the batches anymore. I write down all the lot numbers, but they've all been good. So something they're doing right, in my opinion. But have you tried the brand that we're using?
Yes.
Okay.
But
I mean, it's expensive.
Very, no, like I didn't really dose myself enough. So rarely anything works with me. So it's actually another tissue bank provided things that had this effect on me. And I was like, whoa, finally, we had something.
At the end of the day, like I told him to his face, like anybody can make an exosome. It's just what the stem cells secrete. But the real question is safety, reproducibility, scale. I met this other guy who was making them in a strip mall. And, it's crazy. Like, most people don't know what a clean room is, the ISO clean room. So
right,
you're only as good as your worst batch. So, that's what it is. Watch the webinar that I did yesterday with Duncan. You'll find it interesting, I think.
Oh, I will. I work with, microbiologists, virusologists, geneticists. I mean, yeah, we take it down to atomic level if we have to. But again, in practice, this is what I'm thinking of first trying it on myself.
Yeah, that's great.
And then but of course we already did plenty of patients, and this is what I'm just trying to say, okay, it's going to be more expensive, but it's like first.
Yeah, I mean, to me, it's like, yeah, I'm just scared of doing something that is maybe not safe, but maybe not as potent batch to batch. So I think they have internal QA processes that are just pretty robust. So, but yeah, I mean, it's not hard to make an exosome, and sometimes people have great results. But again, the whole field is just about safety, and you're basically have every reason in the world to exaggerate and to lie. And so that's where most of these companies are. They just don't even know what they're doing. So Yeah, that's my opinion. I could be wrong.
No, you right. I'm not sure if my point is getting across. Is
Yeah.
that again, the heuristic testing, if that's positive, then yes, then I'm gonna inject in every joint.
Yeah.
Again,
Yeah.
the
But
first
if you buy
IV,
like, yeah, if you buy a big, like, are you buying a bunch of vials from one manufacturer? Is that how you're doing it?
frankly, the whole batch sometimes.
Yeah. I mean, again, good for you. If you have a great freezer and a good way to keep those good, but I just, for me, it's like I don't charge that much because I have a, decent margin. So instead of taking these other manufacturers up, I have the luxury of being low price and the same product. So for me, it's not
No,
worth it. Yeah.
it's not about the money. It's about results.
Right.
So it's again getting results, but so far what seems to be, and I think Duncan also said that he guinea pigged himself with like some massive doses as like safe. So okay, so let's go to massive doses.
Yeah.
Not just IV, but like okay, IV is just indicative, but then you can do intranasal, you can
No,
do
I think it's a very safe
then,
product. Yeah, you can't overdose. Yeah. But I
Right.
do, since you're a PhD, you probably understand the whole way of measuring them with the Brownian motion. And so,
Mhm.
yeah, the light scatter is an indirect measure of particles. So that's really where it gets messy. Unless you're
Right. No,
doing size exclusion, inclusion, then you really don't know what you got there.
right. So the numbers are a marketing game, but then okay, fine. So let me inject. I mean, batches usually are 80 mLs or 160 mL. So that's at least from this guy. So we get a lot, so I can basically then do, you know, presumably like ridiculous amount. I haven't done that yet, but I have people in line basically willing to do that.
Yeah.
And it's like, okay, that's why we're
Yeah.
asking you these questions.
Yeah. No, it's legit. I mean, to me, I don't have time to, kind of guess. So I just kind of go with what has been working thus far.
Mhm.
But thank you for the input. You can send me the name of your supplier if you want. Okay.
Well, I wanted actually, again, to understand you better because a lot of people are mixing basically PRP with exosomes, then stem cells, PRP exosomes,
Yeah.
so, and then that's like going directly into the knees, for instance. I mean,
Yeah, I mean,
so
I
what do you
used to
feel
do
about
that
that?
stuff, and I used to do stem cells. I never really did PRP, but I used to combine with hyaluronic acid. And so we're getting into an aspect of religiosity here. You know, doctors are proud. They go, "Oh, I've been doing it this way for years. It's working great, blah, blah, blah." But, at the end of the day, I just kind of dumbed it down to just the one thing now. I have expired the vials of hyaluronic acid I don't even use. So I do think that when we think about, I don't even know how exosomes work, but if the premise is that they work by being secreted by stem cells, which are brought in by inflammation, which are brought in by PRP, then I'm just cutting to the chase. I could be wrong. But yeah, lots of people say, wow, my method is great. I did a PRP or did a platelet lysate and I combine it with the stem cells and yada, yada, yada. I mean, that's great, But for me, I could just take a shot of vodka or I can have you mix your Long Island iced tea. I don't know if it's better or worse.
No, okay. How about any other peptides that you'd like to do together, like BPC 157 or a few other ones, maybe?
I am so ignorant. People do it. I just interviewed world expert and manufacturer of peptides, Adam Bender. So make sure you're on my podcast email list. But he goes at great length, 50 minutes talking about peptides. Again, I hear great things. It tends to be a slower ramp up for the effects from what I'm hearing, but they can be powerful. But in exosomes, we have a wide therapeutic index. Like even a little can help, a lot won't poison you. And the results are pretty predictable and where the cost meets the consumer is pretty affordable too, in my experience. So,
Well, I'm more like into preparing the terrain, basically. What would you then do?
well, that's the only. Yeah, I appreciate your point. Like the only time I would do PRP or maybe these shockwave things in order to prepare the terrain is to create a situation of inflammation. Because we know that if there's some low level inflammation, then the vascular permeability, the amount of immune cells going there, all the amount of blood flow to that spot will be helpful. But yeah, I don't recommend ongoing inflammation. I had one lady, Russian doctor, was treating her shoulder, and she spent so much money on exosomes, but she kept on zapping it and zapping it and zapping it over and over and over. And I thought that was really starting the inflammation cycle from day zero. So I don't think she did there's a whole pattern in inflammation and recovery. So if you keep on zapping it, you're going to day zero in my mind. So, but yeah, if you wanted to give PRP in a knee and get it really inflamed and then do the exosomes, that might be a synergistic thing. But again, I like to go a little more gently. Already the exosomes can cause inflammation, usually day 3 or 4. So I just have dumbed it down. Thanks for tuning into the Recharge Biomedical Podcast. If today's episode got you thinking, you'll love my book, Exosomes Songs of Healing. It's packed with cool analogies, full color illustrations, and all the science you'll need to understand how exosomes are changing the game in aging and regenerative medicine. You can grab it in paperback, ebook, or audiobook, whatever works for you. Now head over to www.rechargebiomedical.com to check it out. And don't forget to like and subscribe so you never miss another episode. See you next time.